Thank you so much. Our next presenter is someone who needs little introduction, Dr. Krishna Rocha-Singh, who's led VIVA on our mission along the research side, and he's going to give you some updates on what's coming next. Krishna.
Thank you, Michael. Good morning and welcome to VIVA. What I'd like to do in the next little while is to provide you with some emerging insights from the VIVA SFA Nitinol patient-level meta-analysis. At VIVA, we're very proud and often say that we are more than just a dynamic, multidisciplinary meeting centered around the education and care of our patients. As noted in our vision statement, we state that it is our pledge to maintain the highest scientific integrity and promote research, education, and importantly, the pioneering therapies to improve the care of our patients. In that regard, in 2007, we were involved with industry to promote and provide a performance goal as an assessor and a single-arm comparator for the evaluation of bare-metal nitinol stents. This was also endorsed by the FDA and soon became the standard by which all subsequent nitinol stents placed in the SFA, and here's just a partial list of the trials that proceeded using the VIVA comparator as a trial basis. And from a slide from 2007, it was my desire at that time, along with my colleagues, to foster collaboration between physicians, FDA, and industry, and I believe we've done that. We also wanted to provide a least burdensome pathway that would provide industry with a mechanism to bring data into the clinical space and minimize off-label promotion, and I believe we've done that likewise. We wanted to promote some uniform therapy, uniform definitions for the performance of these trials with regards to stent fracture assessment and duplex Doppler definitions, and I believe we've done that likewise. But importantly, we wanted to encourage industry to initiate larger and more robust data sets to allow us to better define exactly where the sweet spot was in patients with claudication and had nitinol stents. This subsequently evolved into a relationship with industry that provided us with 999 patients that were part of these trials noted here. These were selected because they were all adjudicated primarily by the same core lab, and they provided us with longitudinal data through 1 year with regards to stent fractures, baseline TLRs, baseline ABIs, and allowed us to basically make some comparisons. So the methodology here, based on our performance goal, looked at the definition of primary patency of 2.0. In subsequent trials, as the field evolved, there was one trial that looked at 2.5. Intervention equals patency failure in 5 out of the 6 trials that I noted. And then we also looked at clinically driven TLR in 5 of the studies. In one of the studies, it was less clear exactly what was done. Again, with the methods, we actually had patient-level data, and I cannot underemphasize the importance of having access to patient-level data of each trial. It allows for a very robust analysis. The endpoints were treated as binary outcomes. Now, importantly, we did a statistical regression analysis. These are statistical tools that look at correlations among the trials, not just poolability. So we were able to, in this cohort of patients, actually make some statements with regards to correlations. So what did the data set look like? These are de-identified data, again, looking at 999 patients. We were able to show that the mean lesion length was approximately 8.4 centimeters. And here we have the results of patency that were adjudicated in 887 patients. You see here the other elements that have been adjudicated in this cohort. Now let's start looking at the interfaces that this type of data allows us to suggest and analyze. Lesion length was its association with primary patency and clinically driven TLR. You see broken down here at lesion lengths in terciles and the associated patency and TLR rates that go out to 1 year. As anticipated, the longer lesions have reduction in patency and drive TLRs. When you break this down into quartiles, approximately 220 patients per quartile, you see here a similar analysis. When we look at ABIs and we break these down into ABIs as they relate to patency and 12-month TLR, we also see that the baseline ABI is very important and predictive of subsequent events, as noted here, broken down into tertiles. When we look at this in another way, and we actually look at lesion lengths greater and less than 100, and dichotomize ABIs, we see here, again, that an ABI is very important at baseline relative to its lesion length, and then obviously patency. When we add clinically driven TLR here, you would, as anticipated in this cohort, suggest that the poorer patients enter these trials with lower ABIs, longer lesions. And again, this is very important data to suggest. Now, with any trial, an analysis rather, there are caveats and limitations, and these are listed here. Obviously, we only looked at FDA IDE trials, but I think this is really what the cohort we want to look at. There was obviously some issues with regards to cutoffs that were defined, and we did post-hoc analyses with regards to ABIs. These was not pre-specified, obviously, in these clinical trials. However, we did a sensitivity analysis to make sure that with quartile analysis and tercile analysis, we improved the robustness of these statements. Obviously, this was an exploratory analysis of published data, but that's what we want. We wanted peer review, all of these peer-reviewed published data. And then finally, obviously, there was some variation that we have called out as the field moved forward. We obviously understand that, but we feel that these are mitigated by the robustness and the size of this trial. Obviously, the sample size is constrained by the limited data. So in conclusion, the access to robust and identified, independently adjudicated patient-level data allows us really to find the ideal patient, at least through 12 months, that should be subjected to a nitinol stent. And importantly, moving forward, as we do sub-analyses, we can call out specifics with regards to the potential of peak systolic velocities and correlate those with subsequent events. So the question then becomes, what's next? It's my distinct honor to tell you what is next, and that's the reality trial. The reality trial is going to be a trial sponsored and managed by VIVA, and we appreciate the funding source of Medtronic. This will be a multi-center prospective assessment of the safety and effectiveness of vessel preparation using directional atherectomy, either HOC1 or the TurboHawk in long calcified arteries in 250 patients. Obviously, we're going to be doing some very important sub-analyses with regards to a duplex Doppler core lab, an angiographic core lab, and importantly, sub-studies with IVUS, the assessment of calcium and its impact, WIQ, quality of life, and health economics assessment through 2 years. This will be a very important trial, moving the field forward, and I'd like to personally thank Mr. Brian Verrier and Dr. Simona Zanetti and Mark Turco for their internal advocacy in funding this trial. Thank you very much.